Dr. Lim Wee Kiat.
Question 8, ma'am.
Madam Deputy Speaker, with your permission, may I address questions 8 and 9 for oral answer in the order paper, and also questions 71 and written PQ 41 filed by Mr. Gerald Giam for the sitting on 4th of July, please.
Please proceed.
The current claim that is applied to all types of cancer drugs give pharmaceutical companies little or no reason to lower prices and takes away the government's negotiating power. This has resulted in an unsustainable rise of cancer drug prices. If left unchecked, cancer drugs will eventually be unaffordable for the majority of cancer patients. The changes, focusing Medishield Life and Integrated Shield plans, IPs, to cover a cancer drug list, CDL, of clinically proven and more cost-effective cancer drug treatments, improve affordability in two ways. First, it provides the incentive for pharmaceutical companies to price their drugs more reasonably so as to benefit from financing coverage. Since we announced the changes in 2021, we have managed to secure an average price reduction of 30%. For some cancer drugs, the price reduction achieved was over 60%. The lower prices have made more cancer drugs cost-effective, enabling 66 more cancer drugs to be listed for subsidy. Second, nudging utilization of cancer drugs towards proven and cost-effective care will ensure that treatment costs for the broad majority do not rise unsustainably as a result of liberal use of very expensive and novel cancer drugs. These changes will benefit thousands of patients and improve affordability of more cancer drugs for all Singaporeans. The CDL is extensive. We already have a panel of experts comprising senior public and private oncologists and hematologists across various specializations who recommend new treatments for inclusion into the CDL. This panel has approved treatments that cover multiple lines of therapy beyond first-line therapy treatment, as well as rare cancer treatments to the CDL. This has allowed us to include around 50 more treatments onto the CDL since it was announced in August 2021. The current CDL covers some 90% of treatments used in the public sector and is updated every 4 months to keep up with medical advancements and latest clinical evidence. However, we note that there could be exceptions where patients do not respond to treatments on the CDL, and their doctors may exercise clinical discretion to prescribe non-CDL treatments based on evidence of benefit. In these cases, doctors must be prepared to justify their clinical decisions to patients and their colleagues. Doctors must also counsel the patient on its risks, efficacy, and costs so that the patient may make an informed choice. Some patients may still be covered for such non-CDL treatments by their private insurance, such as riders or critical illness plans. In this transitional period, the Ministry of Health, MOH, will put in place measures for the small number of exceptional cancer patients who require non-CDL treatments and are affected by the policy changes. Private patients who have difficulty affording their bills may opt to be transferred to subsidized care at public healthcare institutions. Once patients are in subsidized care, they can benefit from more affordable drugs and medical fees, as well as access a range of financial assistance such as Medifund. All patients can also appeal to use more Medisave.
Dr. Lim Wee Kiat.
I'd like to thank the SMS for the reply. I'd like to ask, since you know that once you change the policy and companies can drop the drug price by as much as 60%, isn't this profiteering? What actions are taken against this company, for profiteering? That's my first SQ. The second SQ is on patients who have rare cancers and are requiring those drugs that is not on the list currently now. What is the mechanism? Is there a mechanism for them to appeal, for them to be added on the ad hoc list? And then what is the time frame for that?
SPS.
I thank member for the question. Actually, the whole intent of this is to make sure the cancer drugs prices are lowered. And actually, the best safeguard against profiteering is competition. In this regard, the Agency for Care Effectiveness uses the established health technology assessments to evaluate the relative value of new drugs compared to existing standards of care. And in parallel, AILS also conducts value-based pricing negotiations to ensure drug prices are competitive. So the financing changes that we made have made a major step to incentivize drug companies to price drugs competitively so that their drugs would be eligible for subsidies, for MSHL and IPN. And because of this, you've seen the promising results that I mentioned earlier. So in respect to your concerns with regards to profiteering, actually the Competition and Consumer Commission of Singapore also has levers to investigate all reports of anti-competitive behaviour and will take action against instances of anti-competitiveness. You had also asked a question on the process, and I wanted to just take some time to explain the assessment made by ACE mentioned earlier. So what they do is that ACE assesses the clinical effectiveness and cost effectiveness using published methodologies that are in line with international best practices. And they draw on clinical and epidemiological and health economic data, compare the incremental costs and incremental improvement in health benefits of the treatment relative to the existing standard of care. So as part of this process, ACE consults the MOH Oncology Drug Subcommittee, comprising of local clinical experts from the public and private sectors to ascertain the clinical value of medicines under evaluation and the appropriate use of cancer therapies based on the clinical clinical evidence. So you were asking also about the timing. Actually, the process has been put up on the ACE website, and so the drug companies that actually wish to participate in this process would be able to time their applications accordingly. The key process deadlines have been put up, and it usually takes about 5 months from submission until the funding decision. And funding implementation typically occurs within 4 to 6 months after a funding decision has been made. But with timely evidence submission, high quality of clinical evidence, and reasonable price pricing for the proposals from the pharmaceutical companies, this will help to expedite it. Since January as well, 2021, the ACE has also established a new process in consultation with the pharmaceutical company to enable cancer treatments to be evaluated for subsidy and MediShield Life in parallel with HSA's regulatory approval process. So under this process, companies will be responsible for providing evidence submission to ACE in parallel with HSA's regulatory approval process. And so this will be done in tandem. And this will bring funding decisions upstream, close to the point of market entry. So they can do it ahead of time. So by the time it comes in, you already allow for it to be put in. And this minimizes the time gap between HSA registration and inclusion into the drug list. I hope that addresses the question.
Mr. Yip Hon Wing.
Thank the SPS for a reply. I have two SQs. First, how does MOH ensure that insurers do not shortchange policyholders who have been dutifully paying their dues, and what recourse do policyholders have to appeal against decisions from insurers? Second, are there guidelines on the premiums that insurers charge, and what is the oversight on this? While patients are allowed to change insurers, many often have little choice in changing insurers due to the coverage of existing conditions and risk loading. Thank you.
Actually, there's an existing regulatory oversight. MOH and MES actually work closely together in exercising regulatory oversight over IP insurers. IP insurers actually have to seek approval from MOH for any changes in terms and conditions, and MAS will take action against insurers if they do not pay claims in accordance with policy, terms and conditions that they've agreed to, or any unfair handling claims. The thing is, IP premiums are set, reviewed, and adjusted by insurers based on commercial and actuarial considerations. So insurers may adjust premiums taking into account the impact of the changes and their own claims experience and other factors. And so insurers have an incentive to help keep premiums competitive to attract and retain their policyholders. So we hope all these changes in the long run will help to moderate premium increases. I also realized that I haven't really addressed Dr. Lim's question about how do they want to go through this process. So they can actually refer the drug to ACE, for ACE to make that assessment. We also note that in the process where there is the private patients, there is that opportunity for them to have direct referral to the public health institutions, and this is where that assessment can also be made in respect of the appropriate treatment, and where there also be subsidies available to that patient.
Mr. Gerald Gill.
Thank you, Madam Deputy Speaker. I'm not sure if my question on the introduction of a National Cancer Care Appeals Board was answered. I understand from the Agency for Care Effectiveness website, which SPS has referred to, that it takes actually about 10 to 11 months from the time the pharmaceutical firms submit their pre-submission form to ACE to the time the Drug Advisory Committee or DAC meets. However, for individual cancer patients for whom time is of the essence, anything more than 1 week may be too long to wait for a decision on a drug subsidy approval. Can we therefore have a National Cancer Care Appeals Board which can make rigorous yet speedy decisions to subsidize drugs for these patients to get the life-saving drugs that they need? The DAC can then take the necessary time to review the drug for inclusion into the cancer drug list to benefit patients at the national level. Secondly, has MOH modeled out how many patients per year will be adversely affected by these changes to the insurance schemes, and how much in cost savings are expected, and what is the price in human lives that MOH is prepared to accept in order to achieve these cost savings? Thank you.
I thank member for the question. I think first off, we need to appreciate that when doctors actually make recommendations for treatment, it has to be on the basis of evidence. All new and existing patients should be properly advised of the proven efficacy, side effects, and costs of the available treatment options, including the financial implications of receiving a treatment that is not on the cancer drug list at the earliest opportunity. So we appreciate that, by creating this drug list, there may be some patients who may require drugs outside the drug list and may face difficulties. This could include patients who already have tried drugs on the cancer drug list and found them ineffective, or patients with contraindications to the drugs on the cancer list. But there needs to be evidence of efficacy of the prescribed drug outside the cancer drug list. I just wanted to make that clear. In respect of those patients on a case-by-case basis, because what happens is that we've provided this lever where there is actually direct referral to the PHIs, and they can therefore get discretionary funding that's available for them, and thereby getting treatment at a far lower cost. And it is through this referral that then the doctors in the PHIs will then be able to assess the appropriate treatment that is meant for the patient who is in that list. The other question related to the number. The number of patients who will be affected by the cancer drug treatment changes is actually constantly fluctuating as patients drop in and out of treatments. And given the ongoing work, we're actually expanding these treatments on CDL. But nonetheless, we have looked at this, and CDL actually covers around 90% of cancer drug treatments used in PHIs, which is the public healthcare institutions. And we've already said that if they face difficulty, they require non-CDL treatments, they face difficulty affording the drugs, we can be referred to PHIs and they can get discretionary financial assistance. I know this is something that is challenging for patients who are facing these situations, but we need to look at the bigger picture, and that is to reduce the ever-increasing drug prices. With the moves that we have made, we have seen reduction. And I think this is something that we need to continue with. We have to help those who are not able to be covered under the list as much as we can. And we also then have to monitor the process as it goes along to see and ensure that on the long run, it actually benefits more Singaporeans when all the drug prices can be moderated and are lowered, because there's an incentive for now the pharmaceutical companies to lower the prices.
Ms. Ng Ling Ling.
Thank you, Madam Deputy Speaker. I want to thank SBS Rahayu for her replies and explaining the ACE process on how cancer drugs are evaluated and negotiated, because bringing the price down really help our Singaporeans. I wanted to ask a question on whether MOH will consider extending the negotiated price, or maybe more clarification, whether the negotiated price is also extended to benefit the private healthcare providers. Because ACE does tap on a committee that comprises of public and private oncologists, and we know as fellow parliamentarians, we all know of a resident or someone we love who have cancer and battling cancer and seek private healthcare for reasons that we all understand because they want to get well. So I just wanted a clarification whether that negotiated price also benefit our private healthcare providers to help our Singaporeans battling cancer. Thank you.
I thank member for the question. The challenge is that private clinics have varied business models and pricing arrangements. So the feasibility of applying negotiated drug prices to the private sector really depends on whether the price controls can be introduced to ensure cost savings are passed on to the patients. And this is also subject to agreement by the drug companies. So this is something that will require further study. We will take this back and look into it and have extensive engagements with the industry.